Hi, it's Alison Feldman back again. I am here to introduce you to Dr. Don Nixdorf, Director of the Division of TMD and Orofacial Pain at the University of Minnesota School of Dentistry. Please remember to type your questions for Dr. Nixdorf into the chat. Dr. Nixdorf, I will now turn it over to you.
Thank you. And so hopefully everyone can see my screen. Today, what I'm going to be talking about is what, at least from my perspective, what I think patients need to know about the differential diagnosis of facial. And I'll be giving you my perspective on this. And with that, let's get started. First, I want to start with disclosures. My disclosures are I'm financially hired by the University of Minnesota. I get research support from the federal government as well as associations. I do get honorarium for lecturing for organizations, companies, and associations. And I have some equity stake in an MRI imaging company, which has no bearing to this content. And I also have consulting agreements with two companies. Also, none of that is going to be brought up in this lecture. So with that in mind, let's get going. So I think when I start thinking about this topic, my first things that come to mind is I think patients need to know what is a diagnosis and how that's kind of working in a healthcare professional's mind. So specifically, definition is to identify the nature of an illness or problem. And so what a healthcare professional is doing is they're making a determination, present or not present. And sometimes we'll call it a case, and we'll usually use a label for that. And it's often operationalized as a gestalt. What I mean is kind of like you know it when you see it. And I'll get into that a lot more here in a bit. Now, I've previously, with the help of a prior resident and trainee of mine, and that's Flavia Capos, we wrote up for TNA, Facial Pain Association, an outline of the data collection process, what information should be collected, how to collect it, and that was included in the Striking Back textbook. I'm not going to reiterate that here. I'm going to go into more detail in thinking about what are the important aspects of how to put that into practice, the stuff that is not always written down. So in my opinion, healthcare provider needs to interpret the information that is often an experience in the patient or a feeling that they have. And we as healthcare providers need to be able to understand it in the same way as a patient. And we use language for that. And language is notoriously imprecise. That's why we have lawyers in this world, is their idea is to make things precise and unambiguous so they're well understood. And even in people that's their job, they still have different interpretations of what the meaning of words are. And so here in the pain field, we're in a process of where I'm trying to understand what a person is experiencing. And they may use words in different ways than I would. In other words, does a patient use the word sharp in the same way that I interpret sharp? And so if you have shared culture, shared understanding, shared language, it's more often to be precise. But what happens when the culture is different? What happens when the language is different? We'd be using words. So those end up becoming a communication barrier. And so from my perspective, those barriers are really difficult to overcome. And so what we end up doing in an orofacial pain perspective is we ask multiple questions around the same idea to, in essence, probe or see if we understand the same thing or we get information that hopefully should all line up. And a better way of looking at it may be using an analogy. And the analogy is, as a provider, I can't take my brain and plug it into, as a patient, their nerves to be able to sense, feel, and understand what the patient is. And we're using this imprecise communication of language to be able to do that. And so communication is a key component. And that's where we have the interviewing skills, that's asking questions and listening, that's looking for cues and using all the different bandwidth ways to be able to pay attention. And the flip side is patients need that same aspect too. But keep in mind the patient is often struggling with chronic pain. There are a lot of things we know come with chronic pain. They come with depression, anxiety comes with chronic pain, sleep problems come with chronic pain. And those are all things that interfere with patients' ability to think clearly and communicate precisely. And so you have this really setup where it's an imprecise process where at least one of the person is known to have some detriments in their ability to communicate. And obviously, the provider on the other side has their own things going on in their life. So you may have two people that have those things going on. And I look down every once in a while because I'm just checking my lecture notes that I have written here to kind of go through that. And so obviously, patients have a lot invested in their visit, and there is some good information that the Facial Pain Association has about how to become prepared for that visit, and what they're really trying to key patients up for is that there are some common things that I've seen throughout my practice that patients will fall into. There's the patient that is the skeptic. They seem not to be as engaged. Often they will be the ones where the spouse or something else like workman's compensation, or there's another reason why they're there. They're not there solely on their own volition. And so they seem to be disengaged from the process. As you can imagine, communication is difficult. There is a person who's kind of the wanderer. The conversation gets off topic and ends up taking up a lot of time, makes it hard for the care provider to get through all the different topics they need to get to. I don't think patients do this on purpose. I think it's how they experience and interact with things. And the language aspect of things is differently used in different people. I have a patient that who is a visual artist. Actually, his art that hopefully my finger is pointing to the right place, that is over my left shoulder. And he's a fantastic artist, but using words for him was really hard. So in his case, that interaction aspect of things, he says, well, I have a hard time with words, but I can draw it, I can paint it, I can present it visually. And so you can kind of see how that plays a role there. And then there is the person who's like a big talker, and they end up, and I think it comes from a place of where patients are very anxious and there's a lot on the line and they want to be able to get as much of the information across. And they end up having a one-way conversation. And that's not communication when it's all going one direction. Communication is two-way aspect of things. And so the first of three main points that I want to make in this talk is one of the things that is important in getting a differential diagnosis correct is there is a communication. It's between the patient and the doctor. That communication needs to be as fluent as possible for that process to work well. Now, this leads me to an excellent quote. It's one that I think of all the time, and it's from George Bernard Shaw. The biggest problem in communication is the illusion that it has taken place. And so after I just finished maintaining the concept that all of what we look at is through communication and it's fraught with error. And so that takes time and it takes that common understanding and shared experience to work the best. So I'm going to work you through a little bit of analogy of some examples so that you can understand a little bit what's on the side of the pain providers. I'm going to use TMD as one example for patients. And this is work that came out of the OPERA study led by some notable researchers around the US. And what they did was they were looking at overlapping chronic pain conditions. And what you see here listed in the lower left side is the 6 different types of patients, or individuals, I should say. One of them was a control, so they had non-pain. There's one group that had fibromyalgia, one TMD, one irritable bowel, one low back pain, and one had headache. And what you're seeing in the upper right are mannequin depictions that the patients drew. So digitally, they had a mannequin of the front of their body, and they colored in where they felt their pain, so anatomic location. And then this was an average of what all the patients gave. And so these represent each of the 6 different the disorders. And when I look at it, I go, 4 look a lot the same and 2 look different. And if you look at the back representation of on the mannequin drawings, I get to the point where I look at this and I go, I think I can figure out in these heat maps which are the patients, which are the controls. The controls are on the far left. They're the ones that are blue. They're the ones saying 0 or very low to a lot of things. And I think I can figure out who the fibromyalgia patients are. They're on the far right. They're the ones saying red. I got pain in a lot of different aspects. But then when you start looking at people with TMD, irritable bowel, low back pain, and headache, which arguably society would say those are different, separate things. When patients visually tell through a less unambiguous, if that double negative makes sense. So in other words are more ambiguous, a picture drawing is going to be less. When they use that, it looks like these are the same. And so I challenge you, which one is the TMD patients in this group? And now you're starting to understand some of the difficulties that we have of being able to depict things because we have a lot of overlapping pain disorders. So in this instance, the TMD is on the second from the left aspect of things, and they look very similar. And I think even though this is a newly published research, I think it's going to be a landmark paper because it does an eloquent job of making this point in that how patients perceive pain is actually very complicated and not very precise. And so now that we know that there is overlapping of how patients perceive these very different disorders that have different approaches to things, let me give you a little hint about the classification side of things. So the WHO, World Health Organization, has worked with the International Association for the Study of Pain, or ISP, and they have this overall classification rubric of pain. And I have a little blue arrow there where the head pain and orofacial pain is into one category. And what we did as a group of people is got together to classify the orofacial pains using the same rubric process as our neurology headache disorder colleagues to have kind of a similar taxonomy, if you will. And that is the International Classification of Orofacial Pain, or ICOP, that was just published. And it's being also associated with a new specialty in dentistry called orofacial pain, that are the people that are non-surgical specialists in pain management, such as myself, looking at face pain, jaw pain, teeth pain, headaches, neck pain, neuropathic pain, and those things that present in the anatomical region. And as you can see, worldwide, and you look at the types of pain, we break it down into all these different aspects. The key components is disorders can be in all the different areas. So you can have, in this case, a post-surgical pain that happens, say, after a tooth extraction that's in the orofacial region. So there will be some co-parenting, if you will. You can have musculoskeletal problems such as jaw muscle pain, jaw joint pain. That's also the orofacial pain disorder. You can have cancer pain that presents in the head. You can have neuropathic pain such as diabetic neuropathy or post-herpetic neuralgia that happens in the face. So you can see how these all interrelate, and the system has put that into consideration. So why I make a big deal of that is I think there is an axiom that people need to really keep clear in their mind. And this analogy, I think, paints the picture well. In my opinion, a diagnosis is like finding a target. When you get the right diagnosis, you know where the target is, and treatment is like shooting at that target, using that analogy. And so you may know what your target is, and when you take your first shots at the target, you may not hit it, but you can adjust, zoom in, and then you'll be most apt to hit it. But if you've identified the wrong target and you're shooting at it, what's the chance you'll hit the right target? And obviously the answer is really low. And that's kind of one of the things that we're dealing with in orofacial pain is, what are these overlapping pain disorders? How are they linked together? How do we disentangle the words and how people present related to the pain to be able to understand what they are? And the more complex cases is when you have multiple orofacial pains overlapping. And so that brings me to my next slide, which is an axiom that we use is pain begets pain. This is the overlapping pain conditions. We know they're overlapping. I talked to you about TMD overlapping. Here's another example of TMD. And this is some research that we recently did. So we did some reviews of our clinical records, and we picked up these rare headache disorders that present every once in a while. One of them called hemicrania continua, and you'll see over on the right side is that we found in the last 6 years we had 6 patients diagnosed with this, and 100% of them presented with a painful TMD diagnosis. So that means if you're thinking of that heat map of local anatomy, they're overlapped in their pain presentation. Now, the patient doesn't know that. They come in, they say, I have pain. And if the care provider is not astute enough to pick up and understand that these overlapping and know how to tease with language and skill that there are 2 disorders, they're not able to encourage a relationship where the patient feels trusted and can kind of share some of these more details and get to the bottom of that. The patient isn't trusting enough to be able to divulge this and understand where the provider is going. It's going to be really hard to make that diagnosis. And in these types of patients, it's hard because one is treated very differently than the other, and the prognoses are very different for both of them. And so if they're not identified and treated, outcomes tend to be much worse. So look at a very different one. So hemicrania continua is a chronic continuous type pain. It's unrelenting. Sunksuna is a sharp pain, unilateral. It's really close to trigeminal neuralgia. It's a longer in duration. It has some other things like autonomic features. And in 6 patients, what we found there, half of them, so 3 out of the 6, had painful TMD comorbid. And TMD can present with a sharp shooting type component. It's usually mechanical, but when it's really severe and there's a lot of hypersensitivity, we think that the nervous system can then have these episodic ephaptic type approaches to the pain, where patients will actually express that type of pain as a shooting component of things, which sometimes can get mixed up with trigeminal neuralgia. Now, unpublished is another headache disorder. We're just getting ready to submit that. That's paroxysmal hemicrania, and all 4 of those patients had overlapping TMD. And very germane to this audience of patients with trigeminal neuralgia and neuropathic pains, we found in a review of our patients, 88 trigeminal neuralgia patients, a little over half of them had co-occurring in the same anatomical distribution as TMD. And so the take-home message here is the patients with orofacial pain often have overlapping pain disorders. And now you add in one of the more common overlapping, migraine, which with TMD is about 30 to 40%. When it gets to chronic migraine, TMD is in 75 to 80%. TMD also exists with neuropathic pain disorders. And so it's very common that patients will have a TMD, a neuropathic pain disorder, and a headache disorder all co-occurring in the same location, that the pains are all interacting with each other. Also in the aspect of one makes one worse, but they're also interacting in changing the characteristics of the pain that make it harder for each of the individual disorders to be identified. So this brings me to number 2 of the 3 things that I was looking at hitting on, and that is communication. And this is the communication where I refer to as, while we may be what people talk about is the information age, we still struggle as providers to communicate between providers. Yes, we have a lot more knowledge, and that knowledge has really driven a specialization in healthcare. And so I make the off the cuff remark. It's like, yeah, now we're all sub specialized. So we know more and more about less and less. And so that can be really good. But what we find then is patients are having to bounce around a lot more and see more providers to get to right where they need to know. And so it's that balance between being a generalist versus a subspecialist, being able to communicate across those aspects of things. And so we're seeing somewhat of a fractionation, I think, of healthcare. And within the siloed and the way humans best operate, it's hard to get communication. And so one would naturally say, electronic health record has been a really big push, large adaptation of that. But an electronic health record doesn't curate information for you. And what I mean by that is, in the old days, you would have a stack for our complex patients. The paper chart would have been literally inches. And in the nowadays, sometimes I'll still have reports that I'll get and stacks of healthcare records that are printed out because I'll review that for a court case. And it's inevitably 4+ inches of double printed health records. And I've got to wade through all this to try and get all that information. And so it's not curated, meaning it's not put into specific ways for me to try and understand it. The timelines aren't lined up. The change in quality of pains, how things happened, aren't always there. So no one's summarizing and putting things together. And so that's where in some of the facial pain association, where they talk about using timelines and ways like that to summarize your information. So it helps get that overview to the provider. It also helps in being able to understand that process, that the thinking that people went through. So myself as a provider, when I hear and understand the process that somebody with facial pain had taken to get to see me in the clinic, I get a better understanding of their thinking, the steps that they got, because then I can get a better understanding of where they're at. I've seen enough patients where I can make some generalizations. I'm not going to be 100% correct, but I kind of can get in that ballpark of kind of knowing where they are. And so that's really important. So the second one is the communication between doctor and doctor is a big part. And so I just talked about the information and the fractionation and the difficulty, but there's another component of communication, and that is the diagnosis and the combined difficulty in communication related to diagnosis, because the information is based on a history, is based on physical exam, or what we call signs and symptoms. They're very imprecise and difficult to collect the same way, so the reliability is fairly difficult. That leads us to then go, should we have some interest in biomarkers? So that's why you'll hear lots of talk about biomarkers. So NIH has had a 3+ year kind of push in the neurosciences for pain-related biomarkers. And the reason being is it is one method of trying to make the messiness and the difficulty in communication of 1 and 2 easier. And so right now there is open calls for validation of biomarkers, as well as endpoints and signatures for pain conditions, so that we can break down some of these barriers related to communications and kind of go on from there. And so then there's this communication aspect that maybe you haven't thought of because it's not one that patients naturally are engaged in. And that's one that I'll describe in this way. It's the pace of discovery. The pace is high. So in other words, more information coming out all the time. There are lower barriers to publishing information. So information can get on the web in many different ways, whether it be journals. Obviously, there's the for-profit where you have to pay to publish your information. Most patients don't realize that there are scientific journals that are out there that have that. So in other words, anyone can get their data into that. The bar is really low to be able to get your information out there. And the rate is fast. So what this, you think of it from a scientific perspective, is the rate, the pace of discovery is high. So there's more signal, there's more information you need to capture as a care provider. But there's way, way, way more noise. There is people that are individuals that are being able to push information out in TikTok and web-based things about what's important and what's not important. I talked about the aspects of information being able to be published really easily. So you're, as a healthcare provider, bombarded with all this information. And I think back to one of my mentors who was an exceptionally good internist. And I can remember this was in the 90s, and this was before the internet was really kind of going on. And at that time, we had stacks of paper journals besides our bed that we would read before we go to bed. And I was a voracious reader, trying to consume all the information related to my area, which was a daunting task that was often um, less fruitful than I would like to think it was now looking back. And I looked at people that had high levels of mastery of many areas, and I was asking them, how do you do that? And basically what he'd figured out is a way of curating the information and learning how to ignore the noise and pay attention to the signal. And the analogy there is it's like skimming the cream off the top. If you're in research, you're looking for all the cream. Yes, you may have to go to try and get the cream that's maybe at the bottom somewhere or in small different doses somewhere else. But if you're a clinician and you need to stay on top of things, you may just skim off the top. You know you're going to miss some cream. Maybe it'll come back later. You'll be able to figure it out. But being able to understand and being able to collect information from known sources. And I think that's one of the ways that the Facial Pain Association does an exceptionally good job for the patient community is that's kind of what they're doing. They're kind of curators of information in some ways. They're kind of vetting things. They're also in that way where they're the first on the front lines, kind of collecting that first step back, collecting from the patients and kind of helping them. So I think that helps with this whole communication aspect of things. So in essence, this third one is the between doctor and the scientific literature communication, and communication is two-way. And so I wanted to bring that up with that. And so before I move into a summation of kind of my point and open it up to questions and answers, I want to make the point that the irony of communication that is the central thesis to this presentation is not lost on me, because while it's all about communication, here I am lecturing. It's a one-way communication. I would say that's not really communication. It's a lecture, and where it's much better if it's two-way. So I do encourage people to ask questions. And so with that, wrapping up, the three most important things in orofacial pain are, you guessed it, communication, 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 just like real estate, location, location, location. We have the same thing going on. And the other aspect is the practice of pain medicine is more of an art than a science. And I'm going to go back. This is kind of that second one where it's the doctor to doctor communication. The people that are going to be most adept are most likely be the ones that trained and learned in the environments where there was a high emphasis of pain management within their training programs. They got that greater bandwidth of communication, the deeper understanding. They got more interactions with patients. They learned how to catch that information and the cultural components of things and the social aspects of it, as well as the psychological aspects. And so it's still that art. We aren't at the stage yet of biomarkers that can start moving from this art and interactive aspect to more where oncology is, where they have biomarkers for a lot of things, where they can kind of really hone in and hone down on things, which has greatly moved their area forward. We're not quite there yet, so we're still in that skills practice art side of things. And with that, I want to say thank you for your attention. Thank you for spending your valuable time listening to me. And hopefully I've been able to get a little pearl of wisdom or two to help you on your journey in feeling better, functioning better, and better quality of life. So thank you again. And with that, I'll end my lecture.
Thank you so much, Dr. Nixdorf. That was a wonderful presentation. I have a few questions for you, but I want to first just comment that you really said it so well in a number of ways with the target and talking about how this is, more of an art than science. Someone once put it to me that they call it practicing medicine because it still has not been perfected yet. And I think that's something that's really important to remember, but I think it's something that also frustrates a lot of people. So what is the best way for a patient to sort of summarize their symptoms, their history, their issues. They don't have a lot of time. Sometimes they feel rushed. So for you, what would be ideal for a patient to come to you with something written, or what's the best way that you think would be for them to do that?
Here's how I like to see it, and what I train my residents about. What I like to see is a timeline, and you can start at the top of the page when something started, and it's from the perspective of the patient. So it doesn't have to be, oh, it's adequate, it's accurate, I got it 100% right. No, I want to understand the patient's journey. So you could say February 20, 2019, had a motor vehicle accident on first onset of my face pain. And then I'm going to want to see like those dates. I'm going to want to see, okay, so February, 1 week later, saw a GP physician, and I want to know, okay, who they saw, what, and obviously their name, so I can relate it through health records and that kind of stuff. And I'm also going to want to know what they were thinking, so what we call a diagnosis, but it can be in lay terms, and then what the treatment recommendations were. So they were thinking whiplash syndrome, prescribed rest, ice, da, 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 and then the outcome of that. And say, okay. And so the hard part for patients to sometimes that I don't expect to be in there is, but I want to see an effort into it, is how engaged people were in that activity. And we know it's a journey. So that means is at the beginning of the journey, someone may be thinking differently than towards the end of the journey. And so I would really like patients to be forthright and say, yeah, when this first started, I wasn't that engaged. And sure, I got these recommendations, but I didn't really follow them that much. And so I usually have a conversation with my patients. There's a big difference between knowing and doing. And a nice example of that is, if we all listen to our mothers, we'd be in a lot better place than we are now. They gave us a lot of good information, but we didn't always do it. And so we're human. We know that there's not a one-to-one. And so as things kind of move through, what I like to see is, okay, so this type of provider, they were thinking this, they tried that, it wasn't helpful, or this was partly helpful, or I had side effects, I only got to this dose on this drug, or I went all this much, stayed there for 3 months, and this was the outcome. So that's that kind of detailed, chronologically point form
Mhm.
all the way through that process. That is a really good starting point, because then I can quickly skim through and see, okay, are there specialties of knowledge that aren't having input yet in this patient? So I could be looking through. Someone has a 10-year history of chronic pain that's really struggling, and I could look through quickly, and they haven't seen a health psychologist. I'm like, how could this person not be suffering and having pain, not impacting their life in a major way? That this is something that they should be thinking about doing. And a quick screen, I can see that that's not there, and so I can ask the question, why? Is it a belief system process? Is it a lack of access to care? Is it a lack of understanding of how it all fits together? And so in that, it helps me set up where I can ask those questions and understand how the patient got to where they are right now, and then what are some of the pathways forward that may make them feel better. Really intuitive question, good one.
Yeah, and I think that wasn't mine, so I can't take credit. But I think that again, that brings up some other really good points. Um, uh, you mentioned, you gave an example of someone who had a motorcycle accident that was the cause of the pain. But for so many people, the cause is what is elusive. And going back to that diagram with the bullseye, a lot of people are not going to get to that bullseye, to that exact specific clear root cause of their pain. And they might hesitate to try one sort of treatment or another, one sort of medication or another, because they don't feel like they're close enough to that bullseye. So can you talk for a minute about how a patient might know, it's okay to take the next step in attempts to try, but maybe you don't want to go to
Yeah.
straight to, the extreme.
Another really good question. Here, I'm going to back up a little bit and tell a personal story. So my mother has some heart issues, and her husband is an engineer, very linear thinking process, and he had a very hard time understanding that the electrical aspects of my mother's heart issue were not all figured out. Even though we know a lot about hearts right now, we know a heck of a lot more about hearts than we do about pain. And as an engineer, it's unfathomable to him that you would start building across a river unless you knew exactly how it was going to end. You would never commit the resources, the time, the risk, and all that stuff unless that was done. So to him, it was just a huge disconnect of how can you start treating this patient without knowing where you're going to go? And the flip side, the healthcare provider would be like, well, I've done a risk assessment. If I do nothing now, the risk is way worse than what it is if I don't do anything. In other words, a person could die of sudden cardiac death. And so even though I may not have a final answer or the answer, taking prudent steps along a process and knowing and reevaluating and reassessing the diagnostic process gives me more information, understanding how people respond, having the opportunity to ask questions in the future. As patients get more educated what's going on, their answers are naturally going to change. We're going to be able to get more information to then tease those things apart. And sometimes we do get to an answer. So those headache patients that had that co-occurring, I can guarantee you that I did not figure that out on the first day. It took multiple visits. It took that relationship of back and forth of communicating, of trust both ways until we got to that aspect to it. And so that unknowing is, I think, a barrier to us as humans because we like to know those details. Some people are more locked in and like to know that, and some are more comfortable with the ambiguous. And we actually choose dentists as residents based on that experience. That can they handle gray? Is it their world black and white? Because if their world's black and white, we have a hard time training them. Same thing on the patient side. If they have a black white fix it mentality, they're going to be very hard to treat because not a lot of stuff in orificial pain is black or white. You got to learn and adapt and become comfortable with some gray. And that's also another role where health psychologists can help patients adapt in that process.
Yeah, and I think a lot of the calls we get at FPA, a lot of the stuff we read on social media, you've mentioned several different subspecialties and subspecialties and so forth. People see neurologists, they see their dentist, they see their primary care physician, they see, et cetera, et cetera. Would you recommend that any one sort of specialist be that sort of overarching go-to doctor for someone with facial pain, and then all of the rest kind of does that make sense?
I think, in my opinion, there are people like me, oral-facial pain specialists. That seems to be an emerging one. I think what our physician colleagues have a really hard time is ruling out dental pathology presenting as pain, especially in patients that have had nerve injury and don't feel their nerves so much, and therefore their normal surveillance skills and apparatus, if you will, doesn't work as well because of nerve injury. And I had a patient that she had nerve injury secondary to surgery for tumor growth. And I was seeing her for TMD and that kind of stuff. And I knew she had the nerve pain and that kind of stuff. And things weren't matching up. And sure enough, it was a dental abscess that was driving her flare up of pain. Now, luckily, she was plugged in and engaged, and we were able to pick that up. But my guess is if she didn't have the nerve injury, it would have been much more easier to pick it up earlier. And so it's that overlap. And so people like me also have difficulties thinking about sinus disease, right? The teeth and the sinuses are right there. So we're interacting with ENT. So it's somewhat that you need to have a person who's comfortable playing the quarterback role, if you will, for a sports analogy. That's
Right.
going to run things. Usually it's a GP that can do that for you, but when it gets into orificial pain, that gets a little bit far afield of what they are. So therefore, people like me are the ones that have connections to primary care areas and disciplines, as well as to the chronic pain specialists, an aspect. And we kind of sit between things. We sit between dentistry and medicine. We sit between the super subspecialized and the generalists, because obviously patients have issues of diabetes and heart disease and general things that primary care should be looking at. But sometimes they also have really high intensity needs, like I mentioned about the patient with a tumor or other types of high invest. So I think that aspect. The other group I think would be headache neurologists. That would be another really good one, especially if the pain is a little bit higher up. What I'm seeing, and how we split up things in Minnesota is basically, if it's kind of eyes down, it's my territory. If it's head up, it's their territory. But it's not hard and fast. They treat patients with facial pain. I treat patients with headache. We send patients back and forth. And there are some things that each one of us are maybe a little bit better. And so it's really a team effort and kind of knowing. And when we meet multidisciplinary, we'll have a talk about it, saying, hey, who's the best person to quarterback this patient? And we'll kind of go that way.
And just one last question. Actually, I'm going to sort of get you to clarify, because I think it's important. We introduced you at the top, but can you explain, what your specialty is and what sort of credentials, if someone is looking for a specialty, someone who practices such as you?
So I'm a dentist. I've done some different things besides dentistry. And I find my physician colleagues will introduce me this way. He's a dentist, but he's not really a dentist, which I always find is interesting, because I'm a dentist and I don't do things with teeth. And so you can almost think of me as like a dental neurologist. And our field is called orofacial pain. It's a newly recognized specialty in dentistry. It's the non-surgical management of things in the face. So I'd say I'm 2 parts neurologist, 1 part physiatrist, and 1 part anesthesiologist. And so we do some medication management. We do a lot of behavioral management. We understand the mechanics and the physical aspect of things. And so there's 10 recognized training programs in the US. And so people that graduate from these programs, since they're accredited, they've been vetted, that they've been taught the right stuff, if there is such a thing. And then if you look for people that have graduated from these programs or teach in these programs and then have went on to get board certified, that means there's an independent group that has assessed their knowledge. And so they've been taught the right stuff and they seem to have got the right stuff in their mind. And that's a really good way. So that'd be called the
Right.
American Board of Orofacial Pain. And
Wonderful.
so those people.
Great. That's so helpful. Well, thank you so much again, Dr. Nixdorf. And for everyone attending, you can go back now to the agenda and choose your next session.
Thank you for your time.
Thank you.